Good afternoon and welcome to this COMPAS panel on the politics of public health. My name is Eric McGilvray. I'm a professor in the political science department here at Ohio State, and I'm the coordinator of this year's COMPAS program on the COVID-19 pandemic. As many of you know, the COMPAS is a program of the Ohio State Center for Ethics and Human Values. COMPAS is an acronym that stands for Conversations on Morality, Politics, and Society. And the mission of the COMPAS program is to promote civil and informed discussion of important and controversial public issues. Obviously, the COVID-19 pandemic is one of the most important and controversial issues currently facing our nation and the world. And today's panel is the first of a series of COMPAS events that will explore the various ethical and political dimensions of the pandemic and the response to it. We'll be hosting panels like this one on Zoom every other Friday from 1 o'clock to 2 o'clock p.m. Eastern Time. And our next panel on September 18th, 2 weeks from today, is called Testing, Quarantines, and Contact Tracing, Privacy in a Pandemic. You can view the full schedule and find information about our many distinguished participants on our website, chv.osu.edu/compass. I should know that by heart by now. It's a great lineup of speakers and events, and I hope that many of you can join us for those events. Today's panel, Lockdowns, Masks, and Social Distancing, the Politics of Public Health, will be moderated by my colleague, Emma Saunders-Hastings. I'll let her introduce our panelists, but first let me briefly introduce her. Professor Saunders-Hastings is Assistant Professor of Political Science here at Ohio State. She's a political theorist whose work focuses on political, economic, and social inequality, with particular attention to the role of social power. She's published articles in a number of leading journals, and her book, Private Virtues, Public Vices, Philanthropy, and Democratic Equality, is forthcoming soon, I think, from the University of Chicago Press. Emma, take it away.
Okay, well, welcome to the panel, and I'm very pleased to be able to introduce our two distinguished panelists. Dr. Denise Jamieson is a medical doctor and public health expert who's had a variety of leadership roles at the Centers for Disease Control and Prevention, including as a medical task force lead for the Ebola response in 2014, and as an incident commander for the Zika response in 2016 and 2017. When she retired from the U.S. Public Health Service as a captain in 2017, she received the Distinguished Service Medal, which is the highest award granted to an officer in the Commissioned Corps, for her notable contributions to reproductive health and public health practice. She's now the James Robert McCord Professor and Chair of the Department of Gynecology and Obstetrics at Emory University, and the Chief of Gynecology and Obstetrics for Emory Healthcare. But her work focuses on emerging infectious diseases in pregnancy. Thomas Wood is a professor in the Political Science Department here at OSU. He studies political behavior, vote choice, and elections, especially the effects of political campaigns. His most recent book with Ethan Porter is called False Alarm: The Truth About Political Mistruths in the Trump Era, which makes the reassuring case that Americans are not invulnerable to factual information. According to his website, another area of research includes, and I quote, the unorthodox dimensions of American political attitudes, such as conspiratorial accounts of political events, and the use of magical thinking when individuals are faced with uncertainty and anxiety. So I think both of our panelists know why they're here. We're going to go in the order that the panelists appear on the program, starting with Denise, who will speak for about 15 minutes. We'll turn it over to Tom, who will do the same. And after that, we'll open it up for discussion between the panelists and questions from the audience. So hopefully it'll be a good discussion, and I very much look forward to hearing from you both. Denise, would you like to start?
Thanks so much, and thanks for the kind introduction. By way of background, we have over 6 million cases of COVID-19 in the United States now, and there have been over 186 deaths. The US is leading the world in infections. And so suffice it to say, we are not doing a great job controlling COVID. I think that our mitigation efforts, our efforts to try and contain the virus, have been woefully inadequate. We need more contact tracing, we need more testing, we need more masking, we need more distancing. And why are we having so much trouble with this? Why are we not succeeding? I think there are a number of reasons. One of the first issues, I think, is that public health is really not an individual sport, it's a team sport. it doesn't work well when you depend on a large number of individuals all independently making good decisions. And in this pandemic, it's not easy to make good decisions. And the reason why it's not easy to make good decisions, I think, are severalfold. The information, there's a lot of confusing information. So in order to make good decisions, you need detailed information about risk. And it's been very confusing, right? What's 6 feet? Why is it 6 feet, not 7 feet? Why is it not 8 feet? Why is 12 feet better than 6 feet? Is inside worse than outside? Why is it worse? Are all insides the same? Are all outsides the same? You know, what is the risk around you? Does it matter whether you're in Ohio, like many of you are, or in Atlanta, where I am? And this is not an original thought of mine, but I think of COVID like a sexually transmitted infection. It's not just the person you were with, it's all the people that they've been with. And so it becomes this very complex, difficult series of choices. The other thing is that it's evolving, right? It's so hard to keep up with the evidence. You know, at the beginning we were told, don't worry about masking unless you're a healthcare provider. If you're a healthcare provider, wear this kind of mask. Now we're saying everybody wear a mask. What kind of mask? You know, how do you wear a mask properly? What masks are okay, what masks aren't? And then I think the most critical part of making decisions, which I face every day, I have a partner and two 14-year-old twin boys. And I'm still working. And so I have to make multiple decisions every day about what's safe or not safe. And I'm a physician who's taking care of patients with COVID. And I'm a public health professional with over 2 decades of experience. And I have trouble making decisions. I have trouble interpreting all the evidence and then making decisions. And by the end of the day, it's exhausting. Last night, I had to make a decision for one of my sons, whether he could or couldn't do something. And like, I was just so flabbergasted because I'm, making decisions all day. And I think it's even harder if you don't have that background. I think one of the other challenges is that Americans prioritize, I think to make a gross generalization, we sometimes tend to generalize our own interests over the collective good. So the whole notion that we've been pushing, that my mask protects you, your mask protects me, doesn't necessarily resonate. And perhaps we need more studies, because I do think if we looked at it systematically, my mask probably does protect me, but we just haven't looked at it in a scientific way to be able to say that. And again, like you look at people who are against, who do not believe in vaccination, most vaccines are really largely for the collective good. So if I don't vaccinate my child, but everybody else around me, their children are vaccinated, my child is safe. And so it's a very different determination of self and good. I think the other big thing that's going on is that our public health infrastructure is failing. So the way public health works are that local and state health departments work collaboratively with our public health agency, which is the Centers for Disease Control and Prevention, or CDC. There are other agencies that are involved in public health, but CDC should be the lead public health agency. And for a variety of reasons, I think that infrastructure is failing. Just in a very tangible way, I think our surveillance systems, the systems that were set up to collect information on infectious diseases, are outdated, and we haven't invested enough. I'm an obstetrician, and I worked primarily on pregnancy issues when I was at the CDC. And every time there was a new outbreak, whether it be H1N1, or Ebola, or Zika, we basically set up anew a surveillance system to collect information about pregnant women with the pathogen of the day. And then after the outbreak was over, there wasn't this sort of resources or political will to continue to fund those surveillance systems. And so I think that's just an example of where we lack the political will to invest in national public health infrastructure. And then the other big factor, which I know has been large in the news, is the lack of trust in CDC as the premier public health agency. I looked up in Wikipedia public health, and it's the science and art of preventing disease, according to Wikipedia. And NIH is more science, I think. It's straight science, and I think that's primarily why they've been more insulated from the current political climate. But public health really blends public policy with scientific evidence. And therefore, it's really critical that CDC steers clear of politics and political interference. And there really needs to be a firewall between the CDC and the rest of the government. And if you look at recent examples, most of which are high profile, many of which are high profile, you'll see that pattern. So look at school guidance. So in May, CDC released evidence-based guidance for schools about how to safely reopen. Trump expressed concern that it was too complicated, too expensive, and then Pence announced that same day that CDC would be revising the guidance. And then in July, CDC published additional documentation about the school guidance, stating the importance of reopening schools. And if you read that guidance, it is very unlike the usually scientifically rigorous, nonpartisan, non-political guidance that CDC issues. And so that sequence of events leads one to wonder whether there was political interference in the process. Another example, quarantine. Since March, CDC had been recommending quarantine after international travel and after travel to high prevalence areas. And with very little fanfare, they dropped those recommendations in August. And so again, how was that decision made? Certainly not in a transparent, evidence-driven way. The third example that's recently been in the news is the issue of testing. So on August 24th, CDC issued guidance that said if you're a contact of a known COVID case, you don't necessarily need to be tested. Well, that's a major deviation from our efforts overall to control the spread. A fundamental part of how to contain this virus is testing close contacts. Since asymptomatic people may be the most prolific spreaders, it's really important, if you want to stop the chain of transmission, to test people who you know are exposed. One way in which this is operationalized is that the MMWR, Morbidity and Mortality Weekly Report, which is a report that's issued by the CDC, is basically the policy document of CDC. It's not peer reviewed in the same way that scientific papers are peer reviewed, because it really represents CDC policy. And it's really critical that that be published without interference from politicians. And if that doesn't happen, then you're jeopardizing making the best evidence-based public health recommendations. And then I think the last sort of big issue impeding our effort to control this virus from a public health perspective are social determinants of health. So the fact that much of what we're recommending, like physical distancing and staying safe, are really measures that you can only implement if you are privileged. So if you have to go to work as an essential worker, or you are at home, but there's no safety net to provide for your rent, your housing, your food, and so forth, then it doesn't work very well. And so I think we haven't taken a larger approach to ensuring that people can actually stay safe and still feed and care for their families. The very last thing is, I think we need clear communication messages. So there's a process by which the plan for the way in which things are communicated seems to not be working very well. We need clear, consistent messages from the experts at the CDC, and I think there's a lot of room for improvement there. So in closing, before I turn it over to Tom, it's interesting because I was looking back this morning thinking about this session, and one of the first talks I gave as a civilian after I had left the U.S. Public Health Service as a commissioned officer, I'd retired, was in October of 2017. And I was talking to a group of OBGYNs. And my second to last slide, I had 3 bullets of observations that I had about CDC. And I think they hold as, more true today than they were then. The first was CDC needs additional resources to deal with major complex responses. So 3 years ago, we should have been investing in a possible pandemic. The second bullet was critical to maintain firewall between CDC science and politics. And the third one was critical to ensure that CDC decision makers are evidence-based and address politically sensitive issues. So with that, I will turn it over to Tom.
Thank you.
Hi, thanks, Dr. Jamieson. It's I just want to assure people it seems sort of jarring to hear from some fairly quaint political scientist after you hear from like an esteemed public health expert, and it's just doctors just have always got this tone of voice. It's reassuring to hear a doctor speak about it, a physician speak about anything. So I'll keep my remarks as brief as possible so we can actually get back to people who are experts on this question. I'm going to share some a very small number of slides on the question of Americans' public the American public's understanding of the COVID crisis. We've got some excellent survey data has become available in the last months or so. So those of you who are playing along at home can make these figures yourselves. And I guess what I want you to take from this is consistent with the concerns that Dr. Jamieson had about erecting a, I should say, you guys can see my slides before I start bothering away. Emma, can you see the? Emma, can you see? Oh, sorry.
Sorry, yes.
Oh, awesome. Thank you. Okay. The positive takeaway is that quite clearly the American public at the start of the crisis was very inclined to trust public health officials. They've been very inclined to trust their doctor, the HHS, the CDC. We have seen some degradation in that, but from a very high base. And really, as a person who studies public opinion, it's pretty remarkable that, how minimal are the partisan differences in Americans understanding the crisis and willingness to engage in the scientifically recommended patterns to slow the spread of coronavirus. And the one concern, the one stipulation I'll have is that the patterns on the data, the trends, the intent to vaccinate are very concerning and very troubling. And so lest you take anything positive from this presentation. What we're looking at first is from the UAS. This is a long-term panel study run out of the Dornsife Center at the University of Southern California. They've recruit with a large panel, about 6,000 respondents, nationally representative. They replace panelists as they drop out off the panel. And what we're looking at here is just, they've been asked since April all the way up to the 1st of September, they've been asking, how effective do you think these different ways of responding to coronavirus are to stop the spread? And it's really pretty remarkable how few of these responses demonstrate any sort of partisan difference. The one you'd expect, of course, is prayer in the bottom left-hand corner. Partisanship is now very strongly related to people's religious practice. But even there, Republicans are far more inclined to think that washing your hands with soap, avoiding contact with people, avoiding public spaces are a more important way and a more effective way to stop the the risk of being exposed and contracting COVID than prayer. Consistent with the pattern of clinical advice that Dr. Jamieson described, as you can see among Americans' understanding of wearing N95 masks. Americans were very quick to respond when the advice changed, and Americans were told, hey, masks, don't worry about them, to quickly pivot to, well, actually masks will likely be quite important. The American public, really within a single wave of this panel survey, doubled the percentage who understood that the N95 mask would be important. And then again, the indication for the troubling trends is that as mask wearing became more and more politically fraught, we do see this opening of a partisan difference on the appetite or to wear masks, or the understanding that mask wearing is an effective way to stop coronavirus spread. Dr. Jamieson also indicated there has been some attrition in the venerance with which the American public hold our exceptional, our best in the world, our world-leading public health agencies. What we're looking at here is we're looking at two different waves: the amount of the expressed trust in these different institutions listed on the y-axis, your physician, thankfully, the very, very tippy top, people on social media, thankfully, at the very bottom, as sources of trustworthy information about coronavirus. But the most important thing to take from these data is that you do see this difference between March and July, especially among Republicans, a big decline in perceived trust of the WHO, the HHS, the CDC, and even in county health officials. And so as the crisis continues on, some of the more maladaptive information responses the American public has been criticized for are beginning to emerge. But even the last time the UAS poses this question in July, the CDC is still deemed about as trustworthy to Republican respondents as President Trump and Vice President Pence. And so it's not as if Republican respondents are strictly seeing this crisis and this healthcare, this health emergency through a partisan lens. Even Republicans are far more inclined to say that they trust their physician for reliable advice than their co-partisan president. Very, very modest differences. If we ask respondents what they perceive the chance on the left-hand side between 0 and 100%, the probability that they'll get coronavirus the next 3 months. On the right-hand side, if conditional on contracting coronavirus, what's the chance they'll die from it? The red and blue points indicate the means of the Democratic and Republican distributions. And so you see, it's a very modest difference. The Republicans and Democrats alike seem to embellish, exaggerate the danger that they will catch coronavirus compared to what we've seen as the incidence prevalence from the public health data. But the partisan differences are still very, very modest between Republicans and Democrats on these measures. There's even been consensus on policy response. Here I'm taking data from, not from the UAS, but for data for Progress, a not-for-profit public attitude research company. You can see, if you look, for instance, in the right column, the middle square, we see big differences in single-payer government insurance, known as Medicare for All. This is consistent with theories of public opinion in which the American public learn which political issues go with which side of politics. But if you ask Republicans if all Americans should receive free treatment for coronavirus, 3/4 support. If you ask Republicans if we should expand unemployment insurance to help workers laid off during coronavirus, overwhelming support, 3-to-1 support. Majority support government providing financial assistance to private companies so that they can minimize the financial risk to American workers as a result of being furloughs and layoffs. And so it is pretty remarkable, given the tenor of the partisan debate during the crisis, that unless a specific policy question has been subjected to overwhelming partisan criticism, the American public still has a broad set of policy preferences on which they have bipartisan consensus and support. And you might even also imagine it's surprising that Democratic respondents are also so supportive of these policy responses, given it was not a co-partisan president who implemented them. But finally, if you want to take away a very distressing conclusion, going back to the UAS, what we have here is recording respondents intent to vaccinate once a vaccine is available to the public. The dots on the far right hand of all these facets indicating the percent unlikely, percent somewhat likely, the percent very likely, again, according to respondents' partisanship. These most recent estimates indicate the data that was collected on September 1st. These are very, very recent data. And you see a very troubling trend, even among Democrats and independents, to express increasing hesitance to use a vaccine once it becomes available. And so I almost don't know what to make of these data. In part, like it's reflecting maybe increasing uncertainty and politicization about how safe the vaccine development process is. I might get concerned, for instance, that as the American public hear terms like warp speed and moving with all necessary vigor to bring these vaccines to market, I wonder if they hear those promises and infer something about these vaccines' relative safety. And so it is probably the most consequential attitudinal intervention that we can hope for. And it's the place where the American public is seeming to depart from the scientific consensus most troublingly. And so it is something worthy of close attention and additional research without any question. And so what I want people to take from this very brief presentation of data is that Americans have been pretty robust to misinformation on the topic of coronavirus. Despite sustained campaigns to impugn their integrity, Americans still remain inclined to trust physicians and science agencies. Even Republicans are about as trusting of the CDC as they are their co-partisan presidents. But the one very meaningful and troubling exception to these trends is a declining intent to vaccinate. And it's not simply a result of political factors, because while Democrats continue to provide their co-partisans overwhelming support for the safety and efficacy of these vaccines as they're being developed, even we're seeing Democrats decline in their willingness to report high intent to vaccinate in the future. So we don't have, unfortunately, fantastic answers for why that is, but it's something that's worthy of very, very close attention. And I think some research, not only by public health officials who traditionally do research on why it is that Americans are inclined to engage in some health care behaviors, not others, but I think there's also probably some work for some political scientists to do this work as well, since we are in the distressing sort of circumstance where the previously apolitical health agencies have sort of been dragged into the middle of some of these political debates. And so I promised a few slides, and I feel like I've kept up my end of the bargain, and I welcome the questions.
And so at this point, if you have a question for either or both of our panelists, you can pose it by clicking on the Q&A function at the bottom of your Zoom screen, and we'll start collecting those now, and I'll relay them to the panelists. I want to start by posing a couple of my own that I think kind of cut across our panelists' areas of expertise. So the first one I had is maybe a little bit upstream of some of the issues we've been talking about. The blurb for this panel refers to the widespread skepticism and non-compliance that public health recommendations have met with in the United States. And I take it from Tom's presentation that maybe the skepticism is a little bit less than it's sometimes presented to be. The premise of the blurb, though, seems to be that there is more skepticism and non-compliance in the US than elsewhere. And I was wondering, to what degree do you know or have reason to think that that's true? Do we have good evidence on this? I'm very ready to believe that skepticism and non-compliance are more politicized than they are elsewhere. And I think that might make non-compliance more salient and emotionally charged. But can we be reasonably confident there aren't similar levels of non-compliance in other places that just sort of go about their non-compliance in more relaxed or less politicized ways?
So, I mean, I think we have good evidence from just looking around that people are not adhering to public health recommendations for physical distancing, for example. And I think there's a variety of reasons. But I think also when you look at the epidemiology of, carefully well investigated outbreaks in the US that are linked to parties and motorcycle rallies and other things, I think we have evidence that on a nationwide basis, we are not adhering to public health guidance. I don't know how much of that is skepticism. From where I sit, it seems like people just making poor choices because they either don't believe, or they're fatigued, or they're tired. I'm not sure.
I would just say Jay Van Bavel's team at NYU has a preprint gathering survey data in 45 countries on this question. And interestingly, the American public is about as populist as like a typical Western European country on this question. Western European countries, respondents in Western European countries tend to express higher confidence in public health officials. But there's pretty bad conspiracy adherence on vaccine safety, basically across the developed world. My book in 2018, still available on Amazon. In fact, you'd probably be a pioneer to buy it at this point, and it's very affordable. And I'll just send you one for free. Anybody who mentions the chat. My colleague and I, we found that the idea that there is a conspiracy among pharmaceutical companies to suppress natural cures, that's basically the most stable and popular conspiracy among the American public. The idea that federal health regulators are beholden to the financial contributions of the pharmaceutical industry. That predates coronavirus. That predates a fairly populist incumbent president, of course, and so. The acute circumstances of the current lack of confidence among elites, or elites denigrating public health officials in the United States, are without doubt exacerbating these trends, but we also should be wary of inferring too much. There's a lot of magical thinking around health and uncertainty and anxiety around what vaccines are and what vaccines do.
I think the question I had was, what, from each of your perspectives or your disciplinary perspectives, do you think is the appropriate level at which to try to intervene in order to secure better public health outcomes? In particular, should we be focusing on individual behaviors and attitudes, or on institutional changes and remedies? So one question we're talking about is how individuals will respond to policies like lockdowns or mask requirements, and whether we can get better levels of individual compliance, maybe through better messaging or increased trust. But I wonder, is that targeting the wrong place, especially if trust isn't as tightly correlated with compliance as we think it is? What about the institutions that can either take on responsibilities for reducing the spread of the virus, or on the other hand, maybe not do so out of competing incentives, like financial ones? You can pick any example at random, say a university. What about the institutions that are not doing or implementing all the rules that might be effective in reducing the spread? In the case of individuals, it seems to be, well, we're worried they'll act in either short-sighted ways or selfish ways if they think they're in a low-risk group. And the remedy to that, I guess, is to exhort them to behave better or less selfishly, or provide them with better messaging. But would a more promising public policy lever be to impose stricter requirements on institutions whose financial incentives might cause them to deviate from the best public health evidence?
I mean, I think, yes, absolutely. So I think that we need to use the best scientific evidence to make the best policies at a national level that will then be implemented at a more local level. And then we still are dependent upon individuals making good choices, but within a much narrower framework. So for example, in my state, tattoo parlors opened very early, as did bars and restaurants. If you look at and gyms, if you look at the evidence, that doesn't make sense. And so, and there was no guidance from at the federal level, and then no guidance at the state level. And so then you're either leaving it up to individual institutions, or worse yet, to individuals to make good, consistent choices. And that's where the whole thing breaks down.
I would just say, like, Emma, when you're talking about institutions, one that comes to mind is Facebook. And for they have been like a pretty reluctant participant in dealing with political misinformation. But their aggressiveness in dealing with misinformation around COVID, hats off to them. They have been very receptive to the media researchers, the psych researchers who've argued that they should be very aggressive about removing labeling and suspending accounts that traffic in COVID misinformation. To your point, it's as clear as you can possibly imagine, a mismatch between the financial incentives and the public health incentives. We can probably infer Facebook's reluctance to more aggressively police their platform is because users don't like it. Users don't like when their auntie is red flagged for being a vector of public health misinformation. But it's turned out to be incredibly effective. And in fact, at the conclusion of this talk, I'd encourage folks to pull out their phone. The way that Google has changed their search results for COVID has been really impressive. I mean, by my estimation, quite impressive. Compare the way, if you went back to YouTube 2 years ago and tried to look up information about the MMR vaccine, the YouTube algorithm very reliably vended wildly inappropriate, scurrilous conspiracy theories about vaccines being the vector for MMR. And YouTube's engineers would just say, those are the videos that do the best on our engagement. Those are the videos people click and spend a long time on. Our users love those videos. And without criticizing CDC, the CDC videos reporting the science will come on the third or fourth page of the YouTube results. Google has been much, much more aggressive now. It's very hard to find misinformation accidentally on the YouTube, on the Google interface. And I just want to suggest, we needn't take too many opportunities to be nihilistic about this approach. Simple engineering fixes are within the reach of these large companies to massively improve the public health understanding of their users. And I would expect that by the time we've done the studies from these interventions, I anticipate that we'll have very positive evidence for their effect.
Well, at this point, I'll start bringing in questions from the audience because we have a growing queue. I'll come back to some of mine if there's time later. First, there's a series of linked questions, I think, about the CDC, responding to Dr. Jamieson's point that there needs to be a firewall between the CDC and politics. So two people ask, how does this work, assuming many recommendations would still require money allocations from government? And another points out that the implementation of policies requires cooperation from the rest of the government. So is there a structural problem here in the American political system that blocks good implementation of CDC guidance? Another question points to aspects of the CDC's own behavior, asks, can the CDC recover its reputation for independent evidence-based policy after the end of the Trump administration, given the current overtly partisan tone of the agency? If it can, how long will it take? Or will it now become an agency within the federal government which can be seen as an extension of whatever party's in power, like the EPA sometimes is?
So in terms of the firewall, it's I'm talking about a very particular, specific part of public health implementation. The role that the CDC plays is that they synthesize the best science, they collect and synthesize the best scientific evidence, whether it be surveillance, outbreak investigation, variety of other methods. And then they use that information to make the best evidence-based public health recommendations. And then, and that piece on a very practical, the way that that happens is the MMWR, as I mentioned, is really the the public health policy arm of the CDC. So those recommendations are published. And then the way it used to work is when you had one MMWR or a series of MMWRs, there would then be a communications rollout plan where the CDC folks would, in consultation with others, decide how that should be best implemented. And when I say others, that includes people in the communities, people in the private sector, as well as other parts of the government, how to implement it. And then that would be clearly and consistently communicated to the public and to state and local health agencies. The piece that has to be a firewall, I believe, is the synthesis of the scientific evidence and the formulating of the best evidence-based recommendations. And then how those are implemented then becomes a broader conversation. But if you have parts of the government saying, the White House saying, you can't say that a contact should be tested. I'm using this just as a hypothetical. You can't say that this person is, you can't recommend that they're tested, even though the evidence shows that the best way to contain this virus is to test all contacts of known cases, then you've got a problem. So I'm not to say that the firewall, that a lot of what the CDC does has much broader implications that affect a lot of different parts of our government, but that synthesis piece should not be influenced. The evidence piece shouldn't be influenced by politics, the scientific evidence. And then the second part of the question is about CDC and can it be an independent organization, an agency? I think absolutely. I mean, the amazing thing to me is despite all the kerfuffle that's going on in the media and everything that's going on around us, if you look carefully at the quality of the MMWRs that are being published today, they're incredibly carefully thought out, thoughtful pieces. And it reflects the fact that there are really talented, dedicated, incredibly smart people still grinding away at the CDC, doing incredible work. The problem is, what are we doing with that work? That's where the rub comes in. So yes, I think with strong leadership, I think the bones of the CDC are in great shape. What's not in great shape, in my opinion, is the way the agency is being led.
I will just say just very quickly, look at the way that the CDC has traditionally been represented in the American public imagination. You know, like, they are the good guys in Hollywood movies about diseases. The American public regards the CDC as the people, the cavalry who charge in and save the day. And that's why, in part, it's sort of tragic that in the midst of a proper modern pandemic in the United States, they haven't been able to sustain such a sort of a position outside and above the American political fray. And again, like, I don't know how much we can attribute to like the CDC, their responsibility. And as Dr. Jamieson said, some of the allegations as to sensitivity to political concerns probably has damaged the standing of the organization among people who pay attention to the news on a day-by-day basis. But I would anticipate that it would go back to existing as sort of the apex of the American public health infrastructure in the imagination of the American public. And the people who can, like, you know, provide public health when the American public needs it most urgently. I think it's so recent, of course, that during Ebola, the CDC enjoyed such public veneration for how effectively they dealt with threats to the American public then. And so I would be optimistic that with a different administration, the CDC would revert to that level of prestige.
We've got a few linked questions about possible influences on skepticism and non-compliance. So to the degree that you're willing to speculate about the role these are playing, I'll put a few of them to you together. So one person suggests that the president is playing a role and asks whether you think Americans should stop listening to the president. Another asks whether the media cycle and sort of headline click-grabbing headlines is influencing a distorted perception of what's going on with COVID. Hold on, I've just lost that question. Whether the ever-revolving media coverage of the coronavirus news and the reduction of science to attention-grabbing headlines is what's causing people to become more and more hesitant about vaccination. And a third person asks whether skepticism and non-compliance have been influenced by differences in the original responses by different governments to the pandemic. And if so, in what ways?
I had two thoughts. One is about the question about should we stop listening to the president about COVID-19. Absolutely. I mean, the president is not a public health expert. We should be all of us, including the president, should be deferring to those who have deep, wide, and thoughtful subject matter expertise in the area of COVID-19. Those are the people we need to be listening to on matters of COVID. On other matters, we listen to our, governmental leaders. But absolutely, I would not be wanting to get public health advice from someone without deep knowledge and understanding of the situation. In terms of the headlines, I mean, I think the press are trying to, and for the most part, are doing a fairly good job of trying to cover what's going on. It's complicated. I think one of the issues is why there's so many headline-grabbing news stories is because the public health world is not communicating issues in a way that are easy to digest and easy to understand. There's no consistency of messaging. And so I think that's the problem. It's the science and epidemiology are evolving. And so we need experts to help us all understand as the pandemic evolves and as things change, as we learn more every day, to be able to interpret that in a meaningful way. That's not being communicated clearly and consistently. And so then you're just left with this scattershot of stuff that is very hard to interpret.
I guess I would say, yes, listen to physicians like we all should. That's part of the reason that we specialize in things, and the people who are experts for a reason. Without mentioning any specific political leaders, I guess I would just encourage people to think in their life, have they ever heard their doctors or public health officials recommend natural cures? That's not the sort of thing that a thoughtful, informed person does. And so I think they should discount the advice of people who imagine that there is a natural cure to a pandemic. And if a person makes that recommendation, you shouldn't be listening to subsequent recommendations that person makes, as a rule of thumb.
There's actually been a few more questions coming through about influences on perceptions and willingness to comply as well. Someone asks whether there have been studies that show, in addition to the partisan differences, Tom, that you talked about, any significant gender differences in protected behaviors or socioeconomic differences.
I see Kevin's question that the gender differences are modest. The SES differences are large, but they're mostly just tapping education. So it turns out to be the case that, thankfully, for those of us who work in public education, the more the higher your educational attainment, the more adherent you are to expert advice, especially in public health. So yes, there are education differences, and they appear as SES differences if you only look at income.
A couple of other people, Ryan Miller and Gerald Helsinki, have raised, I think, linked questions as well about the effect of perceptions of fairness. So we might think that what determines people's willingness to comply with requirements is just their perception about the absolute magnitude of health benefits that will be secured by their compliance. But a couple of questions in the queue now point to, we might also be influenced by our perceptions about the fairness of the distribution of burdens. For example, when small businesses are required to close or go out of business while larger companies get bailouts, where urban and rural areas might be impacted differently by some of these policies. This is going to be probably the kind of thing I imagine that the CDC should refrain from pronouncing on directly if we're trying to maintain that firewall. But is perception of fairness an important ingredient of an effective response that could secure compliance from people?
In terms of fairness, as I mentioned, I think there are real issues in terms of our safety net. So I work at a inner city, urban, busy hospital. Many of my patients are uninsured, and I'm starting to hear the same pattern of behavior, the same story over and over again. And the story roughly goes like this. And as I mentioned, I'm an obstetrician, so I work on labor and delivery, and patients come in, and we're testing everyone. And a couple of interesting things: we're testing all women who present in labor, so that we know whether they're infected or not. It's been fascinating because, number one, we have two hospitals that are less than a mile apart, and the rate at the hospital with higher SES and insured patients is much lower, as you would expect, than the hospital where I primarily work on labor and delivery. So that's the first thing. And then all the factors that you'd expect to be associated with being positive hold true. So women who are from areas, areas with more crowding, areas with lower socioeconomic status and so forth are also more likely to be infected. But the story that I get, time and time again is a pregnant woman comes in, she's in labor, she tests positive, she's surprised, and she says, "Oh my goodness, how did that happen?" When the pandemic started in March, I quit my job, even though it was a huge financial drain on my family. But we got together as a family and decided this was super important for me to be healthy during pregnancy. So I quit my job in a nursing facility so that I could stay home with my two kids. And it's just been us at home. And, it's been terrible, but I did it so I could stay safe and not get COVID. And I said, "Well, is anybody else in the home with you?" "Well, yes, my husband, he works at a chicken processing plant north of here." And because somebody had to be bringing in income. And so it's that pattern that, people don't have the privilege to be able to fully protect their families. And so I think the answer is a better safety net. There was also a study about lockdowns in Denmark and Ireland, and they showed that during the periods of lockdown, pregnant women had better birth outcomes. They had a lower rate of low birth weight babies, which is remarkable because we've been trying to figure out how to reduce prematurity and low birth weight for decades, and we've made very little progress. So all of a sudden they saw a dramatic drop. Now, and the author speculated that that's because women didn't go out and weren't exposed to other pathogens. They weren't exposed to environmental environmental pollutants, and there was less stress because they didn't have to work, they didn't have to go outside the home. And these were in countries where apparently there's more of a safety net. And so the lockdown period was not stressful. And I thought it's the exact opposite in the United States, where the lockdown, from what I am seeing, has been extraordinarily stressful for people, particularly people who don't have the means to financially withstand a lockdown period.
All right, the next question should be a quick one, but I'm going to pose it to Denise. It's a good opportunity for public education. Someone asks, if the vaccine came out within the next 2 months, do you think it will be reliable and a good idea to give it out to college students?
Yes. So I am really excited about the vaccine. I believe that there will be a safe and effective and available vaccine in the not too distant future, probably not before November, probably not before the end of this calendar year. But from what I can see, the number of vaccine candidates and the preliminary data look very promising, and I'm really excited. And I would certainly want to get the vaccine and want my family to get the vaccine. There's also been a lot of concern about the speed at which the vaccine is being developed. I'm not concerned about the speed, but I do think we need to make sure that we don't cut corners.
So I'll ask a question that's been troubling me a bit. Do you think it's possible for the professional obligation that people at the CDC have to tell the truth and convey information about the best evidence we have about this disease, for that requirement to ever conflict with the messaging that we expect to be most effective in eliciting behaviors that will produce good public health outcomes? Question for both of you, I guess. And if it's possible for those objectives to conflict or for those requirements to conflict, and if we want the CDC to stick to the evidence, to the strict truth, whose job is it to engage in messaging that's going to be most successful in getting us good outcomes?
I mean, I believe in accurate and transparent communication when it comes to public health. I don't think there's ever an advantage to not be truthful and transparent. Sometimes, you know, it can be difficult. I think it's important to frame things carefully, but I just don't see any advantage of miscommunicating scientific truth.
Emma, like, what are you thinking about when you pose that question? Like what sort of conundrums are posed to you, like in that context?
Thinking about, in the case of the recent pandemic, the initial instruction to not wear masks, because apparently there was a concern about people buying masks and using them.
Right.
And so there was initially statements to the effect that they're not necessary, they're not helpful. Fortunately, it seems like that reversed and the information was corrected. You could think also about when I took health in junior high and university, we were told that every partner is at equal risk of contracting HIV from unprotected sex. It's not actually the case that a man having sex with a woman is as at risk as she is of contracting HIV, although you can see why that might be a useful belief for people to have. So this is the kind of case I'm thinking of where would it seem tempting, if not for a public health agency, for somebody to frame things a little differently for utilitarian reasons.
Thankfully, the former CDC official makes it clear that the CDC would never contemplate such a thing. Yeah, and so my own research would indicate that we have underestimated the public's epistemic vigilance, especially on something like this, when they realize the stakes are incredibly high. That Republicans still hold the CDC in higher perceived domain-specific trust than their own co-partisan president in the immediate run-up to a presidential election. In a sense, it's demonstrating the weakness of the political differences, and that reassuringly, when the stakes are so incredibly high, the public has been quite discriminating in their sources of relevant information. I mean, as you say, and it's fair to say that the American public has not been well served. You know, advice has changed a bunch. A podcast like TWIV, This Week in Virology, is now common listening for lay people for no other reason that it's really, really hard to find very technical, dispassionate consideration of the evidence from specialists. Just because, I mean, it's amazing to me, I know we're getting it short on time, but there have been no press conferences from CDC during this crisis. That stuns me. Like you would think that the American public who want to get past politics would just say, no, on the CDC YouTube channel at 3 p.m. Eastern every day. And they haven't done, it seems like a tremendous thing to leave on the table as a way for dispassionate information to be provided in the most direct way.
Denise, would you like the last word on this?
Yeah, I agree completely. And that's what I was referring to with the communications rollout plan. Press conferences were a key part of the overall communication strategy. And you've got to do it frequently because the messages change. So I agree.
Well, that's our buzz, so we're out of time for today, but please join me in thanking both of our excellent panelists and in rejoicing in the knowledge that apparently people can handle the truth. I'm very happy to hear it. Thank you, Denise. Thank you, Tom. And thank you, everyone, for attending.
Thanks,
Bye.
Emma.
Thank
Thank
you.
you.